Hello guys, sorry for being late today, a little late today. Had some issue, that's why we are starting a little late. Having said that, now in last class, we are discussing about the gastrointestinal pathology, right? We have seen all the esophageal disorders like esophageal diverticulum. We have seen about achalasia cardia, gastroesophageal reflux disease, esophagitis, the types of cancers that occurs in the esophagus. Okay, so that's the squamous cell carcinoma of the esophagus and the adenocarcinoma of the esophagus, the risk factors. Okay, and what are the infectious causes of esophagitis. So all these topics we have discussed in the last class. Now in this class, let's continue. Now let's begin with the problems that occurs in the stomach. Okay, the gastric pathologies, the exact gastric pathologies. Now esophageal pathologies are completed, the gastric pathologies. Now look here in the topmost image, okay, the image which is shown on my top. So that's actually the stomach. Okay, that's actually the stomach. Now here the stomach, it's looking like, the stomach, it's looking like a brain. Okay, you can very clearly see a gyri and sulci kind of appearance. Okay, so a gyri sulci appearance that is shown over here. Just 1 minute. Okay, so here you can very clearly see the gyri and sulci kind of appearance. So this is called as, okay, cerebriform appearance of the gastric rugae. So it is seen in which condition, sir? The disease which I am going to talk now, it is Ménétrier's disease. Okay, so Ménétrier's disease. So in this Ménétrier's disease, what happens is there is foveolar cell hyperplasia. Okay, there is foveolar cell hyperplasia, sir. Now you can get it out. What exactly are these foveolar cells now? Okay, what exactly are these foveolar cells? The foveolar cells are the mucus producing cells in the stomach. It's not the goblet cells. The foveolar cells are the mucus producing cells in stomach. Right? Now why, sir? Why exactly is this foveolar cell hyperplasia? The reasons are not very clearly understood, but in these patients, it was shown that the TGF alpha, okay, transforming growth factor alpha, okay, so the transforming growth factor alpha levels are super high, elevated. These levels are elevated. Because of that, the foveolar cell hyperplasia is seen. Now, whenever these foveolar cells, okay, whenever these foveolar cells, which are also called as the surface mucus cells, the foveolar cells are also called as surface mucus cells. Whenever they are undergoing hyperplasia, now the stomach is going to look like brainy kind of appearance. So this is called as cerebriform appearance. Okay. Cerebriform appearance of the gastric rugae. Okay. Now, in this condition, what is the problem? In this condition, as the foveolar cells have undergone hyperplasia, now what do you think? More mucus production or less mucus production? What do you think? So these patients are going to have more mucus production. So unnecessarily excessive quantities of mucus is going to be secreted. High levels of mucus secretion is going to be seen. Whenever there is high mucus secretion, the patient is going to go into hypoproteinemia, sir. Okay, mucus is a form of protein, right? Mucin is a protein. Unnecessarily too much proteins are being secreted into the stomach. So what happened to the person? The person will go into hypoproteinemia. Okay, hypoproteinemia, sir. So these patients, important point, these patients are at a risk of developing adenocarcinoma. Okay, gastric adenocarcinoma means these patients in the future they can develop the stomach cancer. Okay, gastric adenocarcinoma, the most common cancer of the stomach is the adenocarcinoma, sir. Okay, this is not an esophageal cancer. Esophageal cancer is completed. That's the adenocarcinoma of the esophagus, which is seen as a complication of GERD. That's completed, sir. This is a total different thing. This is the gastric adenocarcinoma, which is seen as a complication of this Ménétrier's disease. Even here, you can very clearly see, so there is hypertrophy of the gastric. I should say that there is hyperplasia of the foveolar cells. The foveolar cells have undergone hyperplasia. So too much amount of the glands, these are the glands, whatever you are seeing, these are the glands, too much amount of glands in the stomach. Okay, that's what gives the cerebriform appearance or brain-like appearance of the gastric. Okay. Having said that, now let's begin with the most important topic, that's the gastritis. Okay, gastritis. So what exactly is gastritis? In the name itself, it is a gastritis. Gastro means stomach, you know it. Itis means inflammation. So it's the inflammation of gastric mucosa. So the gastric mucosa is getting inflamed. Okay, there is inflammatory changes that are happening in the gastric mucosa, sir. Now, before going to the topic of gastritis, I should tell you what exactly is something normal and what exactly goes wrong. Okay, so there are certain mucosal defenses. There are certain mucosal defenses or mucosal protective factors. Defenses are protective factors. Okay, protective factors, which means these factors, whichever I am going to discuss, they will always try to help in the production of the gastric mucosa. They helps in the production of good amount of the gastric mucosa, the mucus secretion. Okay. Now, what are the damaging factors? There are certain damaging factors, always. Damaging factors. So, what are the damaging factors? See, the damaging factors we'll discuss. First, let me write the damaging factors. So, what do you think are the damaging factors for the gastric mucosa? Which factors can cause damage to the gastric mucosa? Acid, first acid. The acid secretion, sir. The acid secretion, okay, that is the HCl. Okay, acid secretion is a damaging factor. Or this is also smoking. Okay, smoking, acid secretion, drugs like non-steroidal anti-inflammatory drugs, NSAIDs. Okay, non-steroidal anti-inflammatory drugs, what exactly they do, I will discuss. Next, certain infections like Helicobacter pylori. Say this infection with the Helicobacter pylori, smoking and alcoholism. See, these are all the damaging factors for the gastric mucosa. So they will start to damage the gastric mucosa and can lead to the gastric inflammation, gastritis. They can cause the gastritis. True. Now, what are the protective factors? The protective factors are going to be, number one protective factor, right? It's a mucosal blood flow. Say, I am just writing this in broad letters, because this is the very important thing. The mucosal blood supply, the good amount of mucosal blood flow is very important for the proper production of the mucosa in the stomach, or the mucus production in the stomach. Okay, so this is the protective factor. And the bicarbonates, HCO3 minus, bicarbonate secretion. See, these bicarbonates, what they will do, the bicarbonates will start to neutralize the acid. They will neutralize the acid. Okay, bicarbonates neutralize the acid. So, acid won't damage the gastric mucosa. So, it's a protective factor, sir. Mucosal blood flow and bicarbonate secretion, these are the protective factors. Now, if there is any imbalance, right, note, if there is imbalance, okay, that will lead to gastritis. Okay, there should be a proper balance between the protective factors and the damaging factors. What happens, for example, if the protective factors are going down, okay, there is decrease in the mucosal blood supply, or if there is any decrease in the bicarbonate secretion in the stomach, or if there is too much amount of acid production, too much excessive intake of this non-steroidal inflammatory drugs, means the damaging factors are increasing. If there is any such imbalance, that imbalance can lead to the gastritis. Okay. So now, how many types of gastritis are there? Okay. So gastritis, it's of two types. What are they? The two types of gastritis are acute gastritis, chronic gastritis. Acute and chronic gastritis. Acute gastritis, chronic gastritis. Okay. Now, acute gastritis. What exactly? This is seen with which usage? The acute gastritis, you all know. For example, whenever you take these painkillers in excessive amounts, okay, for example, there are many people who will complain. So, whenever they take these painkillers, they start to have this pain in the stomach. Okay, gastritis, inflammation will start to happen. So just taking the painkillers can trigger the gastritis. That is going to be acute gastritis. It's not going to be chronic. It's going to happen just like that. So acute gastritis is going to be seen with taking non-steroidal anti-inflammatory drugs, important, or if the patient is in stress. Okay, if the patient is in stress condition, or if the patient, or if the person is taking drugs, or you should say not the drugs, smoking and alcohol, intoxicants. So using of these drugs, the patient under the stress conditions, in the stress condition, and smoking and alcoholism, they will lead to acute gastritis. Okay, they can lead to the acute gastritis, not the chronic gastritis. Immediately, just like that, the gastritis can start, acute gastritis. Then in which people the chronic gastritis is seen? Chronic gastritis is not going to be there for a few times, it's going to be there for longer duration. So not just acute, it's going to be there for longer duration, years together. So chronic gastritis is again of two types. Okay, chronic gastritis is further divided into two types. Type A chronic gastritis, type B chronic gastritis. Type A chronic gastritis and type B chronic gastritis. So I used to remember something like type A always starts with the A letters. The type A gastritis is because of autoimmune damage. Okay, it's autoimmune gastritis. So the autoantibodies are produced. These autoantibodies will start to attack the stomach. Okay, they will start to attack the gastric mucosa, so leading to the gastritis. So autoimmune disease, right? It's not going to be there for 1 day or 2 days. It's going to be there for longer duration. So chronic gastritis. Okay, so autoimmune. So autoimmune gastritis. See here also they go. Letter A. Type A is autoimmune gastritis. Now type B, I used to remember something like B for some bacterial agent. Bacterial agent is causing the gastritis. So type B gastritis is infectious in origin. What is that bacteria? Helicobacter pylori. H. pylori. Okay, this Helicobacter pylori is the organism which is going to grow in the gastric mucosa and will cause the inflammation over there. Okay, so here in this slide we have seen what are the types of gastritis. There are two types of gastritis: acute gastritis and chronic gastritis. Acute gastritis is because of the smoking, alcoholism, using of the drugs like non-steroidal anti-inflammatory drugs and stress conditions. And the chronic gastritis is further divided into type A gastritis as well as the type B gastritis. Type A gastritis is autoimmune in origin and the type B gastritis is bacterial in origin. Type B gastritis is because of Helicobacter pylori. Now let's begin with the acute gastritis. Okay, so for example, if the patient is using non-steroidal anti-inflammatory drugs, so what happens if the patient is using non-steroidal anti-inflammatory drugs? Let me write here acute gastritis. Okay, the patient is using drugs. Which drugs? General normal drugs only, non-steroidal anti-inflammatory drugs, NSAIDs. Okay, non-steroidal anti-inflammatory drugs. So the patient is using non-steroidal anti-inflammatory drugs. These NSAIDs are going to inhibit cyclooxygenase enzyme. Okay, COX, cyclooxygenase enzyme in the body. So when the cyclooxygenase is inhibited, what happens? So the prostaglandin production in the body goes down. The prostaglandins will start to come down. When the prostaglandin levels are getting decreased, whenever there is decrease in the prostaglandin levels, there will be vasoconstriction in the body. Okay, the prostaglandins are the one which causes the vasodilation. When prostaglandin levels decreases, vasoconstriction will occur. Okay, vaso is constriction. Whenever there is a vasoconstriction, what happened to the blood flow? Blood flow decreases. Blood flow decreases to what? Generalized, yeah, everywhere to every organ the perfusion is going to be decreased, but also to the gastric mucosa. So vasoconstriction decreases the blood flow. Okay, decrease in blood flow to gastric mucosa. Okay, decrease in the blood flow to the gastric mucosa. Whenever there is decrease in the blood flow to the gastric mucosa, now see the blood flow to the gastric mucosa, the blood supply to the gastric mucosa is one of the most important protective factor. Now the protective factor is going down. When the protective factor is going down, what happens? There is a chance that now there is an imbalance. Whenever there is an imbalance, that this acid, whatever is getting produced in the stomach, the acid, whatever is getting produced in the stomach, it can actually damage the gastric lining and can lead to the ulcers. Now the patient can develop the ulcers. Okay, simply like that. So this is how if the patient is using the non-steroidal anti-inflammatory drugs, the cyclooxygenase pathway is going to be inhibited, the prostaglandin levels comes down, there will be vasoconstriction, there will be subsequent decreased blood flow to the gastric mucosa. When the blood flow to the gastric mucosa decreases, the acidic damage can occur that can lead to the formation of the ulcers. Okay, so this is the one point which I want you to know. And not only this, I want you to add 2 more important points here. When the patient is in the stress, okay, when the patient is in the stress, then also the patient is going to develop the ulcers. Why? Because the stress can also cause the vasoconstriction. At the end of the day, there will be decrease in the, okay, there will be vasoconstriction. In the stress, during the stress condition also there will be vasoconstriction. I'm not going in detail how stress is going to cause the vasoconstriction, but stress will also cause the vasoconstriction. So that it's going to cause the decreased blood flow. So that's going to cause decreased blood flow to the gastric mucosa, that will lead to the ulcers. Okay, so remember this one point. Now, after this, let's discuss about the chronic gastritis. Okay, chronic gastritis. Now, you know, chronic gastritis is of how many types? It's of 2 types. Type A, type B. So type A chronic gastritis, type B chronic gastritis. Type A, let's write one by one important points. Type A chronic gastritis, it starts with the letter A. I have explained you, it starts with the letter A. So type A chronic gastritis is autoimmune in origin. Okay. So it's autoimmune gastritis, autoimmune gastritis. Okay, so autoimmune, as I'm saying, so autoantibodies are going to be produced. Okay, autoantibodies are produced. So these autoantibodies are going to attack which cells? See, autoantibodies are produced. The antibody should have to go and attack something, right? So the autoimmune antibodies are going to attack parietal cells. The parietal cells in the gastric mucosa, the parietal cells in the gastric mucosa are going to be attacked. Now, you know, in the gastric mucosa from your physiology, I hope you have already studied, the parietal cells in the gastric mucosa is the one which produces the acid. It's the one which produces the acid. Now the parietal cells are being attacked now. When the parietal cells are getting damaged, getting destroyed, so what happened to the acid production? Just tell me. So the acid production is going to come down. There is going to be decreased acid production. Okay. And the intrinsic factor production. The parietal cells, not only they produce the acid, but they also produce something called as the intrinsic factor, IF. The intrinsic factor is also going to come down, sir. Now whenever there is no acid, parietal cells are completely damaged. Depends, sir. If the more parietal cells are damaged, the acid production comes down more. Okay. So because of this decreased acid, there can be echlorhydria. Okay. Echlorhydria, it's the other term for decrease in the acid. A means no. Chlorhydria means no HCl. The acid production is coming down because of the damage to the parietal cells due to autoimmune antibodies. So the intrinsic factor is also going to come down. When the intrinsic factor is not there, vitamin B12 absorption is not going to occur. From the terminal ileum, B12 absorption is not going to occur. So when the B12 is not there, that's going to cause anemia. Okay, that's going to cause the anemia, sir. So this is in general about the type A gastritis. The type A gastritis is autoimmune in origin. So the patient is now going to have echlorhydria. Now the reason why I am telling you this is because most of the students will think, so it's the excessive acid. It's the excessive acid is going to cause the gastritis. More amount of acid is going to cause the gastritis. But look here, see, it's the autoimmune destruction. It's the autoimmune disease that's happening in the gastric mucosa. Okay, autoimmune destruction of the gastric mucosa, especially the parietal cells, is causing the inflammation. In this condition, the acid is not at all there. Echlorhydria, sir, even there is a possibility that without even acid there is inflammation. The inflammation is because of the autoimmune destruction, okay, not because of the acidic damage. Okay, so here what is happening to the gastric mucosa? The gastric mucosa will start to undergo atrophy. So here it is atrophic gastritis. It's the atrophic gastritis. Atrophic gastritis means there is atrophy of the gastric mucosa because of this damage. Now what happens is, these antibodies, whatever are getting produced, do you think the antibodies are going to only damage these parietal cells? So the autoantibodies are damaging the parietal cells. Okay, the inflammation have started, right? Now as there is inflammation that is happening in the gastric mucosa, not only the parietal cells, the surrounding cells will also undergo damage. So what are the surrounding cells? The surrounding cells are the chief cells. So the chief cells are also going to be getting damaged. This is called a secondary bystander mechanism. Okay, that is secondary bystander mechanism. As a secondary bystander mechanism, the chief cells are also going to be affected. You know, the chief cells are the one which produces the pepsinogen. Chief cells produces the pepsinogen. The pepsinogen will be later converted into pepsin. Pepsin helps in the digestion of the proteins. Now, the chief cells are going to be damaged. When the chief cells are damaged, what happened to pepsinogen? Pepsinogen levels decreases. Okay, pepsinogen levels decreases. So, protein digestion is also not going to occur properly. Okay, protein digestion not occur properly, sir. So, these patients, what else you need to know? So, these patients are at risk of developing cancer, sir. Okay, adenocarcinoma. Adenocarcinoma of stomach. Okay, adenocarcinoma of the stomach. Autoimmune gastritis or the atrophic gastritis can lead to adenocarcinoma of the stomach. Okay, now you can ask me, sir, one important point, sir, gastritis is happening, okay, but in which region, sir? This type A gastritis or the autoimmune gastritis is going to occur, especially in which part of the stomach? So these are the different parts of the stomach. See, now I am going to talk, see, this area is called as the body. In the body of the stomach, the most common site for the type A gastritis. Type A is going to be seen in B. A is seen in B. Okay, A is seen in B. So type A gastritis is seen, the most common site is the body of the stomach, sir. A is seen in B. Type A, it is seen in body of the stomach. Okay. So after this, what else I need to teach you? So type A gastritis, A, देखो here A, here also autoimmune, A, achlorhydria, one more A, anemia, one more A, atrophic gastritis, one more A, okay, adenocarcinoma of the stomach, one more A. Okay, so these are the important points which I want you to know. After this, let's discuss important points about the chronic gastritis. Okay, gastritis, yes, it is divided into type A, that we have completed already, and type B, that we have to discuss now, type B gastritis. The type B gastritis, already I have explained you. So the B for the bacterial, okay, because of some bacterial infection to the gastric mucosa. This bacteria would love to, okay, for this bacteria, it's like a honeymoon spot, sir. Our gastric mucosa is like a honeymoon spot. It is going to stay there and it is going to cause a lot of mess over there. Okay, so the most common site is going to be the antrum, okay, near the lesser curvature. So B is seen in A, B is seen in A is seen in B. Okay, type A gastritis. Type A chronic gastritis, A is seen in the B. A is seen in the body of the stomach. Now B, the most common site is antrum. Okay, near lesser curvature. Near the lesser curvature, sir. Now it's because of which organism? It's because of the Helicobacter pylori. It's because of the Helicobacter pylori. Now if I show you the Helicobacter pylori organism, it's going to be like this. This is the organism, is going to have lots and lots of flagella from one end. From one end, it's going to have lots and lots of flagella. This is the bacteria. So it's going to have the lophotracheus flagella. From one end, it's going to have a lot of flagella, lophotracheus organism. So this Helicobacter pylori, it's a gram-negative organism. Okay, it's a gram-negative organism. Now this organism, okay, what it will do? It's having certain defenses. Okay, it's having certain weapons. So if it's simply growing in our gastric mucosa, that's okay. Okay, let it live. Okay, let's live and let it live. But it's going to cause a mess over there. It's having certain weapons. So with this mass destructive weapons, it's going to cause a damage over there, sir. Okay, damage to the gastric mucosa. Our immune system will also try to attack this organism. So during this warfare, our gastric mucosa is going to be damaged and inflamed. Okay, so let me write important points. This is this Helicobacter pylori. It is having urease. It's a urease positive organism. This urease, what it will do is, okay, it's urease. It helps in the production of ammonia, NH3. Okay, so this ammonia, what it will do is, it helps in acid neutralization. Now the acid cannot do anything to this bacteria because the acids are successfully getting neutralized. because of the production of this ammonia, because this organism is a urease positive organism. Now in the stomach, it have to first adhere, right? Like, adhesion should be there. This organism have to stick on to something. So this organism, it have something called as adhesin. Okay, this adhesin molecule, it helps in adhesion. Adhesion to gastric mucosa. Now, this organism, it produces certain toxins, sir. CAG. No need to remember like in the full forms. Okay, CAG as well as VAC. Okay, CAG and VAC. So these are the toxins which are produced by this organism. This CAG and VAC, they are the toxins. Okay, these are the toxins which will cause inflammation, which will cause the gastric inflammation. Okay, now if you look at the ulcer, okay, it's going to cause inflammation. So it's going to cause inflammation. Not only the inflammation, these patients can also have the ulcer formations. Ulcers can also occur in the stomach, sir. Okay, the peptic ulcers can also occur as a consequence. So if you do the microscopic examination, how the ulcers are going to look like? Now, ulcerations are going to be seen. Yes, of course. Ulceration with fibrinous exudate. Okay, ulceration with the fibrinous exudate along with lymphocytic germinal centers. Lymphocytic germinal centers. Very classical appearance. The lymphocytic germinal centers in lamina propria. Now, in the lamina propria of the stomach, now there are so many number of lymphocytes. Why these lymphocytes are coming? Like, lymphocytes are coming because there is an active inflammation going on. There is some bacteria over there. Now, in order to kill the bacteria, so many number of lymphocytes are going to come over there. Inflammation is there. And these lymphocytes, they forms the germinal centers. Now, the lamina propria, it looks like a lymph node. So, it actually looks like a lymph node because germinal centers are present in the lymph node. Okay. So, look here. See, in the lamina propria, so many lymphocytes are there. Okay, so many lymphocytes are there, forming what? Forming germinal centers. Okay, forming germinal centers. So many lymphocytes are going to come. Okay, and what else you need to know? Okay, what else you need to know is, sir, what are the stains which are used to identify this Helicobacter pylori? Okay, so the stains in Giemsa stain, yes, Giemsa stain can be used, like, normal H&E stain, like hematoxylin eostin stain can be used. Same, but the important stains which are asked in the exam are the Warthin-Starry stain, the silver stain. See, with this Warthin-Starry stain is a silver stain. Okay, Warthin-Starry silver stain. You can use silver stains and non-silver stains also, but Warthin-Starry stain is a silver stain. See, you can very clearly see these organisms. Okay, all these black dots, whatever you are seeing here, this rod-shaped bacteria, all these are the Helicobacter pylori. So, what is the important stain that is used to look for the Helicobacter pylori? It is Warthin-Starry stain. Warthin-Starry stain. Not only Warthin-Starry stain, you can use the Giemsa stain. Even here, you can clearly see it's like small dots which are present in the lamina propria. They are nothing but the Helicobacter pylori. So what I am trying to put into your mind is, sir, under microscopy, immunohistochemistry can be used. Okay, immunohistochemical stains can be used to look for the Helicobacter pylori. The small dots are the Helicobacter pylori. But for your exams, just remember the Warthin-Starry stain is the stain used for Helicobacter pylori. And not only that, you can also see these germinal centers. Germinal centers are seen in the lamina propria. Done, sir. Okay. Next, let's discuss about the peptic ulcer disease. Okay, so the two types of gastritis are completed, the chronic gastritis as well as acute gastritis. Now, let's discuss about the peptic ulcer disease. Now, what exactly is this peptic ulcer disease? Simple. Peptic ulcer disease means ulcers are there in the stomach, sir. Ulcers are there. Okay, ulcers are coming. Now, where exactly the ulcers are coming in the stomach as well as the duodenum, sir? Okay, so this peptic ulcer disease, it can be of two types. What are they? What are the two types of ulcers? You can have ulcers in the stomach. So, gastric ulcers can be there. Okay, gastric ulcers and duodenal ulcers. Gastric ulcers and duodenal ulcers. So, if the ulcers are coming in the stomach, it's called as a gastric ulcers. If the ulcers are coming in the duodenum, they are called as a duodenal ulcers. What is the most common site? The gastric ulcers, the most common site is antrum. Okay, the most common site is going to be the antrum, same lesser curvature, sir. Lesser curvature. Now, where we have shaded, so the type B gastritis, B is seen in A. The type B gastritis is also the most common site of the type B gastritis because of the Helicobacter pylori is again antrum near the area of the lesser curvature, true. Now, if I am the patient, see, if I am the patient who is suffering with the gastric ulcers, what are the clinical features going to be? So, the patient is going to have the clinical features like whenever I start to take the food, okay, whenever I start to take the food, the more acid is going to be produced in my stomach. This acid will go on cause more damage to the ulcer, irritate the ulcers. So, upon taking the food, whenever I take the food, there is going to be severe pain, sir, severe pain. I cannot tolerate that much pain. So, I will go for the vomiting. Because I just want to take out the acid from there. Otherwise, the acid is continuously irritating the gastric ulcers. Okay. So, the clinical features are going to be pain on eating food. Okay, pain on eating. Pain on eating food. And in order to relieve the pain, what I am going to do? Pain relieves on vomiting. Okay, pain relieves on vomiting. Next, so now what do you expect? These patients are going to be having normal weight, or the patients are going to lose their weight. So these patients cannot eat the food, so they don't like to have the food because it's causing them pain. So these patients are going to have weight loss. Okay, these patients are going to have the weight loss. Okay. Next, apart from that, these patients, what else can be seen in these patients? Okay, these patients are going to have the ulcers which are forming in the stomach, right? The ulcers are having in the stomach, right? So these ulcers will start to bleed. Okay, these ulcers, now if there is more damage, they will bleed, sir. So along with vomiting, these patients can have hematemesis, the bloody vomiting, hematemesis. Okay. Okay, these patients can develop the hematemesis. Now if the ulcers are growing, for example, continuous damage, the patient is not taking the proper care, he is not taking the proper medications. Okay, he is from a rural background, he is not having proper the medical assistance. So these ulcers can grow and they can lead to perforation. There is a possibility of perforation. Okay, the complete holes, the ulcer is growing, all the layers of the GIT, all the layers of the stomach, I should say all the layers of the stomach are involved and they can lead to perforation possibilities there. And not only this, last but not the least, very important, there is a chance that these gastric ulcers, very, very bad thing, these gastric ulcers can turn into cancers. Okay, these ulcers can turn into cancers. So risk of gastric adenocarcinoma. There is a risk of gastric adenocarcinoma, sir. So these are the important points which I want you to know. The most common site is going to be the antrum near the lesser curvature. The patient is going to have the pain, especially while he is taking the food. So the patient is going to have for the vomitings, go for the vomitings in order to relieve the pain. These vomitings are going to have the blood because these ulcers may bleed. The ulcers may bleed and the patient is going to have the hematemesis. Not only that, there is a risk of perforation and these ulcers may turn into cancers. Okay. Now let's talk about the duodenal ulcers. Important points about the duodenal ulcers, sir. Ulcers in the duodenum. Okay. Now what's the most common site? Most common site. Just simply remember, if you ask why, sir, why ulcers? Why ulcers? Gastritis can lead to ulcers. Okay, we have seen, right, the gastritis can lead to ulcers as a consequence of gastritis. There can be ulcers. Okay, as simple as that. Now, what's the most common site? This is the proximal duodenum. Okay, so I like duodenal ulcers, sir. I like duodenal ulcers. Okay, later I will tell you the reason why. Okay, see here, the patient is having pain. Definitely, if the patient is having the ulcers in the duodenum, means he is going to have the pain. But pain relieves with taking the food. Okay, pain relieves on food intake. Okay, the pain usually relieves on the food intake. So when the patient is taking the food, first food will start to come into the stomach. Now when the food is in the stomach, now in the duodenum what happens is the mucus production increases. Okay, when the food is in the stomach, the mucus production, the bicarbonate secretion increases in the duodenum. So that actually gives some relaxing effect. okay, the pain relieving effect, okay, pain relief with food intake. So these patients are not going to have the weight loss. These patients are not having the weight loss, but usually in some patients, not everyone, some patients may even have the weight gain. Okay, the patients may even have weight gain because they love to eat the food. Why? Because eating food decreasing their pain. Okay, no weight loss. The patients are going to have weight gain. Now, in severe cases, see, duodenum is not like, not like stomach, sir. Duodenum is below, like, the duodenum is little far, right? Little far away. So, if there is any bleeding in the duodenum, most probably it will come out in the feces, not like, the bleeding cannot come in the vomiting. Yes, there is a possibility it can come, but most of the time the bleeding which is happening in the duodenum, it will go along with the food, and this bleeding, the blood, sir, is not going to be fresh blood. All this blood have to go through all the intestines so that the patient can have melena, okay, the black colored stools. The black color is because of this hemorrhage that's happening in the duodenum. Okay, it's not hematochezia. Hematochezia is the fresh bleeding that's coming out in the stools. It's not the hematochezia. I'm talking right now about the melena. Melena is the black colored stools. It's because of the bleeding. Okay, melena. Okay, so duodenal ulcers can bleed and can cause the melena. Okay, now why I like the duodenal ulcers is because when compared to the gastric ulcers, these ulcers are good. They do not possess any risk. For the cancer. Okay, no risk. No risk of cancer. Usually, they do not cause the cancer. Okay, so these are the important differences between the gastric ulcer as well as the duodenal ulcers. Okay, now here you can clearly see. So this is how the gastric ulcer is going to look like. So here is the ulcer, sir. Okay, these are the ulcers. Now here also see, most probably here there is so much inflammation that is happening. So actually here in this condition the gastric ulcer is turning into cancer, sir. Okay, the gastric ulcer is turning into cancer. Now here it's almost a precursor stage for the cancer. Okay, because the gastric ulcers can cause gastric adenocarcinoma. Here also see very beautifully the lining is there, very beautiful lining. But in this region, the mucosa is gone. Now here there is the ulcer. This is the area of the ulcer, sir. Okay, and the biopsy, it's very clearly shown. In this area, there is no proper lining and mucosa is also not there. So this is the area of the ulcer. Okay, see how it is. Okay, here also now here this is the normal proper lining in the stomach. Okay, columnar epithelium is there. Here also normal proper columnar epithelium, intact mucosa is there. But this area, now here there is a loss of mucosa. So there is ulcer. This is the area of the ulcer, sir. Okay. So now after this, the important questions which I want you to know are: what is the most common complication leading to the death? Most common complication leading to death. Leading to death. What do you think? What might be the reason why this peptic ulcer disease can lead to the death, sir? Bleeding. Okay, I personally know a few students who died with the bleeding. Okay, the bleeding in the bleeding with the ulcers, the gastric ulcers. Now duodenal ulcer. So the duodenal ulcer, if it is bleeding, what is the artery involved? What is the artery involved, sir? See, now imagine this is the proximal duodenum, the first part of the duodenum, sir. Okay, the first part of the duodenum. Okay. See, most of the time the ulcers are going to be seen on the anterior wall. Okay, the most of the time the ulcers will occur in the anterior wall, sir. Okay, anterior wall ulcers are most common. Okay, but see, in the posterior wall, if there is a ulcer in the posterior wall, this ulcer will grow, and this ulcer will deepen, and it will actually cause the damage to a blood vessel which is present on the posterior wall. Okay, so this artery is a gastroduodenal artery. Okay, so this artery is going to be involved in the posterior duodenal wall ulcers. The posterior duodenal wall ulcers can actually cause damage to the gastroduodenal artery. Okay, so the gastroduodenal artery is going to be damaged, and from the gastroduodenal artery, bleeding is occurring, and this bleeding can actually kill the patient. Okay, if there is a little bleeding, if the smaller blood vessels are affected, the patient can have the melena. If there is so much bleeding, that can actually cause the hemorrhagic shock. Okay, the patient can go into the shock and he will die. Now, if the gastric ulcer, if it is bleeding, okay, the gastric ulcer is bleeding, sir. Now, what is the blood vessel that is affected? Artery that is affected. Now, what do you think? The answer is going to be left gastric artery. So, the left gastric artery, LGA, is the artery that is going to be affected in the gastric ulcers, and that will bleed, and that can lead to hemorrhagic shock again. Okay, so having said that, now let's begin to enter into the topic of gastric tumors. Okay, the gastric tumors, now the tumors which are going to occur in the stomach. Now, what is the most common benign tumor? What is the most common benign tumor? See, what is the most common benign tumor of the esophagus? The most common benign tumor of the esophagus is the leiomyomas. Here, the most common benign tumors are adenomas. Okay, the most common benign tumors are called as the adenomas. Adenomas are the not cancers, they are not the cancers. What are the most common malignant tumor? Most common malignant tumor. The most common malignant tumor, here it is adenocarcinoma of the stomach. Adenocarcinoma. Okay, so adenocarcinoma of the stomach cell. That's the most common variety. So adenocarcinoma, what is the most common site? The most common site of the adenocarcinoma is going to be the same again, antrum, in the antral region. Okay, in the antral region, where lesser curvature, near the lesser curvature. Okay, lesser curvature. So in the antral region, near the lesser curvature, there is a chance that the patient can develop the cancer. Okay, look, the type B gastritis, the most common site is lesser curvature near the antrum. Not only that, even the gastric ulcer, sir. What is the most common site for the gastric ulcer? Is the same, antral, near the antral region, near the lesser curvature, and this adenocarcinoma of the stomach also. The most common site is going to be the antral region near the lesser curvature. What are the risk factors? Okay, what are the risk factors for developing the gastric cancer? Okay, in which people the patient, which patients they can develop the stomach cancer, the gastric cancer? Those patients who are having infections with Helicobacter pylori. This is the most important risk factor. Okay, Helicobacter pylori infection. Okay, next type is smoking. Okay, the patient is having like a habit of smoking. Next, the patient is consuming certain types of chemicals like nitrates. Okay, nitrates, Helicobacter pylori infection, smoking, other nitrates. The patient is consuming, like some patients will like to have this, like the food which is totally smoked food. Okay, smoked food. Yes, smoked food. Eating smoked food is not a good thing. Why? Because smoked foods can lead to gastric adenocarcinoma. Patient who is having Ménétrier's disease. Okay, Ménétrier's disease. So what exactly is Ménétrier's disease? Already we have seen. Okay, the patient who is having the cerebriform appearance of the gastric rugae, that increases the risk of gastric adenocarcinoma, sir. Okay, transforming growth factor alpha levels, TGF alpha. Okay, TGF alpha levels are more in that patient who is having the Ménétrier's disease is at a risk of adenocarcinoma of the stomach. People who are having blood group A, we don't know the exact reason, but blood group A, okay, blood group A shows high predisposition for the development of the gastric adenocarcinoma. Most of the people who are having the gastric adenocarcinoma are shown to have blood group A. And this factor number 7, the gene mutations like CDH7, okay, CDH1 gene mutation, CDH1, or the gene for E-cadherin. E-cadherin gene mutations. CDH1 or the E-cadherin gene mutations, okay, are risk factor for the development of the gastric adenocarcinoma. Okay. Next, we have seen also the risk factors. Just a repetition of the risk factors: Helicobacter pylori, smoking, nitrates, smoked foods, Ménétrier's disease, blood group A, and the gene mutations. Like E-cadherin 1 gene mutation, CDH1 gene mutation. Actually, it causes a familial in the families. It causes in the familial gastric adenocarcinoma. Okay, one point is CDH1 gene mutation can cause familial. Like in the families, it runs in the families. Familial gastric adenocarcinoma. Okay, next. In this slide, let's discuss about the classification of the gastric adenocarcinoma. Okay, classification. Gastric adenocarcinoma. So classification based on the different types. Okay, we'll discuss one by one. First type is based on the depth of invasion. Depth of invasion, which means how much deep the cancer is invaded, how much deep the cancer is going. Okay, the depth of invasion. Second one is histology. Based on the histology, we can do the classification based on the growth pattern. Okay. We'll discuss one by one. Based on the depth of invasion. See, there are two types: early gastric adenocarcinoma, late gastric adenocarcinoma. Based on the depth of invasion, early, late. Okay, early and late, sir. What exactly is early and what exactly is late? Sir, in early variant, if you have to say this is early gastric adenocarcinoma, the involvement of the cancerous cells, okay, the involvement of the cancer is limited to mucosa and submucosa. Okay, mucosal involvement and the submucosal involvement is going to be positive. The mucosa and submucosa are affected. The mucosa and submucosal layers are affected in the stomach. Okay, the cancer will invade, right? The cancer now from mucosa it is going into the submucosa, but it is not involving the muscularis and serosal layers. Okay, see, the lymph adenopathy can be present or absent. The lymph node involvement can be present or absent, doesn't matter. Only mucosa and submucosa are involved, sir. In late gastric adenocarcinoma, beyond submucosal involvement will be there. Beyond submucosal involvement, not just the mucosa. Now, submucosa muscularis is involved. Muscularis, the cancer is invading deep, going deep, sir. Okay, so based on the histology, now it's of two types. We can classify same gastric adenocarcinoma under the microscopic appearances. We can divide into two types: intestinal type and diffuse type. Okay, intestinal type and the diffuse type. So what exactly is the difference between the intestinal type and diffuse type? So same gastric adenocarcinoma, based on the histology, it's of two types: intestinal, diffuse. So in intestinal type, there is presence of glands. Okay, the glands are going to be positive. The glands are there in this cancer that's growing. If the glands are present, goblet cells. Okay, the glands are nothing but the goblet cells. If the goblet cells are present in the adenocarcinoma, it is called as intestinal type of gastric adenocarcinoma. Intestinal type of gastric adenocarcinoma contains the glands. Which glands? Goblet cells. Okay, goblet cells are going to be positive. In diffuse type, what is that microscopic appearance that is seen? On histology, what is something specific? What is something very much classical over here is signet ring appearance. Signet, I will show you these images also. Signet ring appearance. Like the cells are the cancerous cells, the neoplastic cells, they are going to look like a signet ring in the ring shape. Okay, in the ring shape. Okay. Next, Based on the growth pattern, how the cancer is growing, sir. Based on the growth pattern, it's classified the gastric adenocarcinoma. It's actually divided into many types. There is a classification called as a Borman's classification. Okay, Borman's classification. Okay, Borman's classification. See, according to this Borman's classification, look. Okay, it's very simple, sir. If the cancer is growing like this, okay, like a polyp, it's called as a type 1. If the cancer is growing like a polypoidal mass, it is called as a type 1. In type 2 cancer, the cancer, yes, it is involving mucosa, submucosa, muscularis, but it's looking like it's growing like an ulcer. It's going like an ulcer. So, fungating or ulceroid, like, in the ulcer form. Okay, ulcer-like growth. Okay, if there is ulcer-like growth, then it is type 2. Type 2. In type 3, yes, of course, it's ulcer-like, but it's infiltrative. Okay, infiltrated. Okay, but not too much, not diffuse infiltration, but little. Yes, ulcer-like. Okay, little infiltration is there. Okay, but in type 4, according to the Borman's classification, type 4, there is a diffuse involvement. The cancerous cells are diffusely involving the entire stomach, all the layers of the stomach. These cancerous cells are spreading. Diffuse involvement. Okay, so diffuse or infiltrative type. The last type 4, this is MCQ. Type 4 is infiltrative type. Okay, type 4 is infiltrative type. The entire wall, the entire stomach, the cancer cells are spreading and the entire wall is involved. It's an infiltrative type. Okay, so now after this, what else I want you to know? See, this histologic classification is there, right? Histological classification into two types. That is the intestinal variant and the diffuse variant, where the intestinal variant is going to have, intestinal type is going to have the presence of the cells, the goblet cells, and I should say the glands are present, and the diffuse type where signature appearance of the cells is seen. No, actually this classification is called as the Lawrence classification. Okay, this classification is called as the Lawrence classification. According to this Lawrence classification, yes, there are two types. Okay, I have found it from the internet. Very simple and important things are there here. According to the Lawrence classification, there are two types, intestinal type as well as the diffuse type. Now, the important differences which I want you to know is, sir, here in intestinal type, which sex is going to be most commonly affected? See, men are most commonly affected. In diffuse type, women are most commonly affected. Okay. In intestinal type, there is gastric atrophy. Okay, gastric atrophy is going to be seen. Okay, atrophic gastritis, gastric atrophy is going to be seen. Okay, men are going to be most commonly affected. Next, apart from that, see, gland formation is going to be there. That's why intestinal type I have discussed. Gland formation is there. Okay, so this cancer, it spreads via the hematogenous route. Okay, there is going to be hematogenous spread is going to be seen. Okay, and what are the gene mutations that are associated? The gene mutations that are associated, the P53 gene mutation, P16 gene mutations are going to be seen, and the microsatellite instability like APC gene mutations can also be seen. So APC gene mutation, P53 gene mutation, P16 gene mutations, 3 gene mutations, APC gene mutations, P53 and P16 gene mutations are associated with the intestinal variant of gastric adenocarcinoma. Lawrence classification, important. Okay, atrophic gastritis. There is atrophy of the gastric mucosa. Men are going to be most commonly affected. Hematogenous spread. P53 gene mutation, APC gene mutation, P16 gene mutation. Okay. Now, diffuse variant. You know already diffuse. Sir, diffuse. Diffuse means diffuse, infiltrative. Okay, infiltrative, diffuse, signature appearance. Already we have discussed. Okay. See, what is the risk factor? Risk factor, I have already discussed. Blood group A is a risk factor, sir. Now they go here. Blood group A is a risk factor, right? So those persons who are having blood group A, yes, they are at a risk of developing the gastric adenocarcinoma. But which type of gastric adenocarcinoma? Diffuse variant of gastric adenocarcinoma. Here women are going to be most commonly affected. Okay, especially it is seen in the younger age group. Younger age group is going to be affected, but intestinal type is seen with older age groups, usually older age groups. Okay, intestinal type is seen with the older age groups. In younger age groups, there is going to be diffuse gastric adenocarcinoma. So here on histology, signet ring cells are going to be seen. The spread is going to be transmural spread or lymphatic spread. Okay, transmural spread, transmural spread or lymphatic spread is going to be seen, but the diffuse variant, but the intestinal variant is going to show the hematogenous spread. Now see here, E-cadherin gene mutations. Okay. This CDH1, okay, CDH1 gene are the E-cadherin gene mutations. So now tell me, E-cadherin gene mutations can lead to which type of cancer? This E-cadherin, it's like a biological glue, sir. It's like a biological glue which keeps the cells intact, which keeps the cells together. But whenever the E-cadherin is not there, this glue-like material is not going to be there now. This, like, the proper junctions are not going to be there between the cells. So there is going to be diffuse spread of the cells, like infiltrative variant. I have shown you. According to this Borman's classification, see, infiltrative, because the E-cadherin gene is not there. So infiltrative, sir, spread. Okay, so all the layers can be affected. Okay, so this is because important E-cadherin deficiency due to CDH1 gene mutation. Okay, so these are some important points which I want you to know. So same things, see, intestinal type as well as the diffuse type, intestinal type and the diffuse type. In intestinal type, I hope you can clearly see here the glands. So these are the glands. Okay, I have found this in the internet, but very simple looking. So glands are seen. Okay. Now in diffuse type, if I just zoom in for you, so these cancerous cells, now look how they are. They are like rings. Okay, they are just looking like a ring, right? Here it's like a diamond and here it's a space. Okay, so they are just looking like rings, signet ring. Okay, the classical one I will show you. See here, this cell. Looking what? It's looking like a ring. It's looking like a ring, sir. Okay, so signet ring cells are going to be seen. Okay, now one more important point which I want you to know here. Okay, the one more important point which I want you to know is, sir, in the diffuse variant, the patient is going to have a Linitis plastica. So what exactly is this Linitis plastica? So Linitis plastica means, see, diffuse, right? Diffuse infiltration. Okay, so all the layers are going to be affected. Mucosa, submucosa, muscularis, serosa, and all these layers, the cancerous cells are invading. Diffuse type. So the stomach is going to look like a leather bottle. A leather bottle appearance is seen. Okay, look here. The patient is going to have a leather bottle appearance with a thickened gastric wall. The gastric wall is thickened because it's having no cancer. It's not having cancer, sir. So this is what exactly the Linitis plastica looks like. Now this is the stomach with a diffuse involvement. Okay, with a diffuse involvement. Okay, in the wall. So look here. Linitis plastica carcinoma, diffuse infiltrates, okay, infiltrates entire gastric wall, okay, without forming. See, there is no intraluminal mass, there is no cancerous mass, sir. There is no cancerous mass. Usually cancers are going to form with a mass, they are going to have a mass, but here there is no such mass, no such intraluminal mass. There is a diffuse involvement of the gastric wall. So now it's looking like a leather bottle. So this is called as a leather bottle appearance of the gastric mucosa. So now tell me, the Linitis plastica, leather bottle appearance of the gastric mucosa is seen in which type? Diffuse type of gastric adenocarcinoma. Here also see how the stomach wall is. Now the stomach wall is looking like a thick leather, sir. So this is looking like a leather bottle. Now you can clearly see here, this is an example of Linitis plastica, a diffuse infiltrative, okay, type 4 according to the Borman's classification. So this is example of Linitis plastica, a diffuse infiltrative gastric adenocarcinoma, which gives the stomach a shrunken leather bottle appearance. Okay, leather bottle appearance with extensive mucosal erosion and markedly thickened gastric wall. Sir. Okay, so with this is also completed. Okay, now next important point is the incidence. Okay, the incidence of the gastric adenocarcinoma. The incidence of the gastric adenocarcinoma in these days actually decreased, I should say. Okay, so the incidence of the gastric adenocarcinoma these days, it's decreased. Okay, in the last 20 years, the number of cases of the gastric adenocarcinoma, like stomach cancer cases, are decreased. Why? What might be the reason? See, one of the most important risk factors, the number one risk factors, in the risk factors I have shown here. The first risk factor is Helicobacter pylori. Now we have better antibiotics, okay, to control the Helicobacter pylori. Okay, so better treatment. For H. pylori. The better treatment for the Helicobacter pylori decreases the incidence of gastric adenocarcinoma. So done. So with this, the gastric cancer topic is also completed. The stomach related topics also completed. Okay. So having said that, now let me show you one image and just tell me what exactly is the problem over here. So what exactly is the problem here, sir? What exactly is the problem here in this X-ray? What exactly are you looking at? See, there is a bubble appearance which is shown here, and here you can see one more bubble. So this is a double bubble appearance. Okay, double bubble appearance. So now this double bubble appearance is seen in which condition? Okay, the stomach related topics are completed. Now here also you can very clearly see the double bubble appearance. Here one bubble, here one more bubble, double bubble appearance. So this double bubble appearance, it is seen in duodenal atresia. So those babies, okay, those babies who are having this duodenal atresia, the baby have born with this. Okay, congenital anomalies. So the congenital anomalies, I have started the intestine, the topic of the intestines. Now, in this first I am talking about the congenital anomalies. By birth, the duodenum have undergone atresia. Okay, it's totally now a blind sac. Now it's like a blind sac, sir. Atresia, closed. It's like a blind sac. See now, the stomach. Here is the duodenum. Now, like this, blind sac. Here is the sphincter, pyloric sphincter. Okay, pyloric sphincter. Now, food will come here, the stomach is going to be distended. Now, the food will come into the duodenum, and the duodenum is also going to be distended with the food or the milk. From here, the food cannot go forward. The food cannot go forward. Why? Because the duodenum is totally atresia, sir. Okay. Now, the food will come here, so that what happens? What happens is, the duodenum is also going to become like this, bulged structure, totally dilated. So, first bubble is the stomach, second bubble is the duodenum. So, double bubble appearance. So, these patients, whoever have this duodenal atresia, okay, so what are the clinical features are going to be? Sir, this is a young baby, now a very, like I should say the newborn baby, a born. Now, this baby is taking the breastfeeding. Okay, the baby is taking the breastfeeding. Now, what happens? So, there is an atresia, duodenal atresia. So, the baby cannot, take the milk. So, after taking the milk, the baby is going to have the immediate vomiting. Why? Because there is a block. The baby is going to have bilious vomiting. Bilious vomiting. Okay, why? Because along with the bile, the baby is going to have the vomiting. Why? Because the bile is going to be mixed with the milk. The bile, now this milk cannot go further because there is a blind pouch. So now, these patients who are having a duodenal atresia, actually when they are in their intrauterine life, during their intrauterine life, actually you can estimate, you can have a predilection that okay, this baby might have duodenal atresia. Do you know how? Usually these babies are shown to be have the polyhydramnios. Polyhydramnios. So what exactly I mean by here is, see, these babies cannot swallow the amniotic fluid because there is a block. Normally the baby will swallow the amniotic fluid. The baby is going to swallow the amniotic fluid and produces the amniotic fluid. Swallowing the amniotic fluid, producing the amniotic fluid. Amniotic fluid is nothing but the baby's urine. Okay, but as the baby, this baby is having duodenal atresia. Do you think the baby is going to swallow the amniotic fluid? No. So the baby is going to show the polyhydramnios. Or I should say the mother is going to show the polyhydramnios because there is a duodenal atresia in the baby. The mother is going to show the polyhydramnios. Okay. And what else on X-ray? Whenever you take the X-ray, there is double bubble sign. Is associated with. It's associated with which condition? Which babies are going to show the duodenal atresia? It's a Down syndrome. Down syndrome. Okay. Down syndrome, sir. So done. Next. Again, one more congenital anomaly. Okay, one more congenital anomaly I am showing you here. Is, guys, can you tell me, sir, what exactly is the problem here? There is a pouch. Okay, there is a pouch that is forming from the intestine. From the intestine, there is a pouch that is occurring. Okay. So, from this intestine, this is the normal intestine. From this intestine, there is a pouch that is forming. So, this is Meckel's diverticulum. Okay. So, they go here, Meckel's diverticulum. Pouching. In yesterday's class, we have seen about the Zenker's diverticulum. We have seen the traction diverticulum. We have seen the epiphrenic diverticulum. The traction diverticulum is an example of true diverticulum. Zenker's diverticulum and epiphrenic diverticulum, they are example of the pseudo diverticulum or the false diverticulum. Now here, this Meckel's diverticulum, let me write one by one important points. Meckel's, okay. Meckel's diverticulum. In this Meckel's diverticulum, what are the important points which you should know? So this Meckel's diverticulum follows the rule of 2. Rule of 2. So what is this rule of 2, sir? This Meckel's diverticulum, it is seen in 2% of the population. Seen in 2% of population. Okay. Now, what is the other 2? See, this is the first 2%, 2% of the population. Sir, the patient is going to show the symptoms. Okay, the presentation is going to be seen before the 2 years of age. Okay, presentation. What is the presentation? I will tell you. Presentation before 2 years of age. Before 2 years, the patient is going to show the symptoms. Seen in 2% of the population, less than 2 years of age, sir. Less than 2 years of age. Now, you can ask me, sir, where exactly is this diverticulum happening? What is the exact location of this diverticulum? The location, the most common location. Okay, the location of this diverticulum is going to be 2 feet proximal. Okay, 2 feet proximal to the ileocecal wall. From the ileocecal wall or from the ileocecal junction, proximal to the ileocecal junction. For example, if here is the ileocecal junction, 2 feet proximal to the ileocecal junction, there is going to be this Meckel's diverticulum. Okay, so 2 feet proximal to 2 feet proximal to ileocecal junction. 2 feet proximal to the ileocecal junction, there is going to be this Meckel's diverticulum. Okay, Meckel's diverticulum. Now, other 2 completed. Now, is there any other 2? So, this diverticulum is going to be 2 inches. 2 inches, sir. The length of this diverticulum is going to be 2 inches. So, 2 inches in length. So, 2 inches in length. Now, what else I want you to know is, sir, this Meckel's diverticulum is an example of true diverticulum. What does I mean by true diverticulum? True diverticulum here, I mean by is all the layers of the GAT, mucosa, submucosa, muscularis, serosa, all layers are involved in this pouching. All layers are involved, so not just the mucosa and submucosa, all the layers are involved. Now, what are the problems? What happens, sir, if there is such a diverticulum, if there is a Meckel's diverticulum, what is the problem? See, sometimes in this diverticulum, there is presence of ectopic gastric mucosa. One more important point, so this is diverticulum, M4, I used to remember Meckel's diverticulum seen mainly in the males. Okay, mainly in the males. Males are going to be most commonly affected than females. Okay, one point I want you to know. So, there is presence of ectopic gastric mucosa. Now, whenever there is ectopic gastric mucosa, what it will produce? So, here it is going to produce acid. Acid production is going to be seen. Now, this acid, what it will cause? It will cause the ulcers. Okay, ulcers in the ileal region. Ulcers in the ileal region, sir. So, one of the most common cause of the ulcers in the ileal region is this Meckel's diverticulum. Okay, so the patient is going to have right iliac fossa pain in the, because of this ulcers, the patient is going to have pain here in this region, sir. Okay, in this region, the patient is going to have the pain. Okay, right iliac fossa pain. Done, right? So, these are the important points which I want you to know regarding the Meckel's diverticulum. Okay, so the 2 congenital anomalies that I have discussed are the diurnal atresia. Diurnal atresia is going to show the bilious vomiting, polyhydramnios. The mother is going to show the polyhydramnios, double bubble sign on the X-ray, and the Down syndrome. The association is with the Down syndrome. And the Meckel's diverticulum M for males. Males are going to be most commonly affected. This is an example of the true diverticulum. It follows the rule of 2, seen in 2% of the population, 2 inches in length. It is most commonly located 2 feet proximal to the ileocecal wall. 2 feet proximal to the ileocecal wall, and there is presence of the ectopic gastric mucosa. The ectopic gastric mucosa is going to produce the acid. That acid is going to cause ulcers. Because of this ulcers, the baby is going to have a pain in the right iliac fossa. There is a pain in the right iliac fossa, sir. Okay. So with this, the congenital anomalies topic is completed. Congenital anomalies topic is completed. Now, after this, the next topic which I want to discuss here is the malabsorption disorders. Okay, malabsorption disorders. Okay, intestines are all about the absorption, right? So let me write here malabsorption disorders. So intestines are all about the absorption of the important substances. If there is no proper absorption, that is called as a malabsorption. Malabsorption disorders. Now, why malabsorption? What might be the reason? The reason might be because of some infections. So infectious causes. Okay. Infectious causes or non-infectious causes are there. Infectious, non-infectious. Now question is, what are the infections which can lead to the malabsorption in the intestines? One is Whipple's disease. Whipple's disease. Second one is a tropical sprue. Okay, tropical sprue, Whipple's disease. Third one is Amoebiasis, Giardiasis. Amoebiasis, we'll discuss about them. Giardiasis. Okay, and one more thing is there, fifth one, that is pseudomembranous. Pseudomembranous colitis. Pseudomembranous colitis, Whipple's disease, tropical sprue, Amoebiasis, Giardiasis, pseudomembranous colitis. In all these conditions, there is some infection going on. There is some infection going on, sir. Okay, some infection is going on, and that infection which is present in the intestines is causing the problem in the absorption. Okay, absorption is getting hampered. Okay, so malabsorption. Now, non-infectious causes include celiac disease, and inflammatory bowel diseases. What are the two important inflammatory bowel diseases? Do you know? The two inflammatory bowel diseases are Crohn's disease and ulcerative colitis. Okay, Crohn's disease and ulcerative colitis. These are the two inflammatory bowel diseases. Not irritable bowel diseases. These are the inflammatory bowel diseases. Okay, inflammation is going on. We'll discuss about them. So now what we have to discuss? We have to discuss about these 5 infectious causes. Okay, there are these 5 infectious causes of malabsorption. Okay, now the first one, let's discuss about the tropical sprue. Tropical sprue in the tropical countries, in the tropical areas, the causative agent infecting the intestines, the causative agent in the tropical sprue is E. coli. Okay, Escherichia coli. It's Escherichia coli, sir. Now, whenever see, the patient is going to have all the malabsorption symptoms. The patient cannot absorb, like, vitamins A, D, E, K. The A, D, E, K, sir, the fat soluble vitamins are not going to be absorbed. So the patient is going to have the vitamin deficiencies. The vitamin deficiencies are going to show the particular symptoms, like vitamin A deficiency can cause night blindness. Okay, vitamin D deficiency can cause rickets. Okay, vitamin K deficiency can lead to the bleeding disorders. Okay, just like that. So the causative agent of the tropical sprue is E. coli. So if you do the biopsy of the intestines, biopsy is going to be non-diagnostic. Nothing is visible, sir. Okay, non-diagnostic. Okay, non-diagnostic, not something proper. So you can ask me, sir, why there is malabsorption? Why there is malabsorption? Some inflammation is going on, right? Okay, inflammation because of this infection. Infection is there in the intestines. Because of this infection, inflammation will start to happen. See, during this inflammatory process, the villi which are supposed to absorb the food, the villi which are supposed to absorb the nutrients, this villi have undergone atrophy. Okay, there is atrophy of the villi. So villi have undergone atrophy. Okay, villus atrophy is seen. Now, this tropical sprue, yes, of course, it affects the intestine, but what is the most common site? Most common site of this tropical sprue is terminal ileum. Terminal ileum. As the terminal ileum is being affected, okay, terminal ileum is the most important site for the vitamin B12 absorption. So, vitamin B12 absorption decreases. So, the patient can go into megaloblastic anemia. Okay, because of the vitamin B12 deficiency, the person can go into the megaloblastic anemia, sir. Okay, so tropical sprue, the causative agent is going to be Escherichia coli. Biopsy is non-diagnostic, not something like specific, but on biopsy what you can see is the atrophy of the villi. That can be appreciated. The most common site is being the terminal ileum. So terminal ileum is affected, the B12 absorption decreases, that can lead to B12 absorption decreases, that can lead to megaloblastic anemia, sir. Megaloblastic anemia. So after this, the next topic which I want you to know is Whipple's disease. Okay, so first infection completed, sir. This infection completed, tropical sprue completed. Now let's discuss about the Whipple's disease. Important points. Okay, as a doctor you should know certain important points. Okay, Whipple's disease. Whipple's disease. Okay, Whipple's disease. Now what is the causative agent? So the causative agent is going to be Trophirima Whippli. Okay, Trophirima Whippli. So this Trophirima Whippli, so this Trophirima Whippli is going to affect the small intestine, sir. It's going to affect the small intestine. Okay, what is the most common site? The most common site, say it's a it's actually, to be very frank, this Trophirima Whippli, it lives in the lamina propria of the small intestine. Okay, right here, lamina propria of the small intestine, especially the duodenum. Okay, in the small intestine, sir. Now this organism is having so many resistance, it's having so much protection that actually it lives inside the macrophages. Okay, macrophages will come and engulf this organism. Okay, macrophages will go and engulf this organism, but the macrophages could not destroy this organism. Okay, so this organism lives inside macrophages. So these macrophages now are going to be filled, they are going to be totally filled with this organism, sir. So these macrophages now they are called as the foam cells. Okay, so these macrophages are called as now foamy macrophages. Foamy macrophages. Okay, now look here, these macrophages, okay, where they are living? Now they are living in the lamina propria. Now what they will do is, look here, sir, see here in this condition also there will be flattening of the villi will be affected, so there will be malabsorption even in this condition, Whipple's disease also. Now look here, dekho, here whatever you are seeing, all these blue color things are, let me show you here, see whatever I am highlighting, all these are the macrophages with this microorganism. All these are the macrophages. Inside the macrophages, the organisms are shown in the pink color. Okay, the organisms are taking up this pink color. So these cells are PAS positive. Okay, PAS positive, I should say, PAS positive. Okay, the stain which is used. Okay, the stains are PAS is a stain. Okay, so these organisms, the macrophages, are going to take up this PAS stain. Okay, but these organisms are going to be diastase resistance. Because even carbohydrates can take the PAS stain, sir. Okay, so these are diastase resistance. When you put this diastase, the color is going to be lost. Okay, sorry, not lost. Diastase resistance. Okay, normally when you put the diastase, the color is going to be lost, but here when you keep this diastase, still the color is going to be maintained, the pink color is going to be maintained. So PAS positive, diastase resistance is seen. Okay, so diastase resistance is going to be seen, sir. Okay, these macrophages are going to take up this stain, PAS positive stain, and it's going to be diastase resistant. Diastase resistance is going to be we usually say diastase resistance, like granules are seen inside the macrophages. They are nothing but the bacteria. Diastase resistance, sir. Okay, so here this is an image based question. These are the PAS positive organisms which are seen inside the macrophages. They will start to grow inside the macrophages. Even macrophages cannot destroy them. So these organisms, they will completely occupy the villi. Okay, they will completely occupy the villi, and they will cause inflammatory changes over there, like flattening of the villi. So ultimately at the end of the day, that will cause malabsorption. Okay, malabsorption is going to be seen, sir. Okay, so Whipple's disease is also completed. Now after Whipple's disease, the next disease which I want to discuss here is amoebiasis. So what is the causative organism? Amoebiasis. The causative organism is going to be entamoeba. One point I want you to know. See, this Whipple's disease is not just limited to the intestine. Okay, Whipple's disease is not just limited to the intestine, sir. Okay, it's not just limited to intestine. The other organs are also going to be involved. One point, other organs involved. Mainly, the joints are going to be involved. These organisms will attack the joints also. Okay, leading to arthritis. The patient is going to have arthritis. Okay. Patient's heart valves, cardiac valves can be affected, so that can lead to endocarditis. Okay, there can be endocarditis. Or the patient's lymph nodes can be involved. Okay. So leading to lymphadenopathy. Okay, lymphadenopathy can be seen, and the central nervous system can also be affected. Patient rarely can go into the seizures also. Okay, so joint involvement, endocarditis, lymphadenopathy, and the central nervous system involvement can be seen. Okay, so having said that, now let's begin with this organism, that is entamoeba histolytica. Okay, amoebiasis due to this organism entamoeba histolytica. The name it's there, entamoebasis. Amoebiasis because of an amoeba, which is called as the entamoeba histolytica. There is histolysis, tissue destruction, histolytica. Okay, what is the most common site? Most common site for this organism, most common site is going to be cecum. Cecum is going to be most commonly affected, followed by sigmoid colon. Okay, sigmoid colon. Cecum is going to be most commonly affected with this organism. Now there is histolytica, histolysis is there, the tissue destruction is there. This organism will start to damage the tissues. Okay, so tissue destruction will happen. So the patient is going to have clinical features like bloody diarrhea. Bloody diarrhea. Okay, bloody diarrhea is going to be seen. See, this entamoeba histolytica, it causes a tissue lysis, tissue damage. It loves to eat the RBCs. It loves to eat the RBC. That's why I will show you the image also. Inside this entamoeba histolytica, how to identify the organism? Entamoeba histolytica. Inside this organism, you actually see the RBCs. RBCs are present inside this organism. Okay. See, the intestines are getting infected. As the intestines are getting infected, there will be malabsorption. Okay, malabsorption symptoms are going to be seen. Okay. So they are causing histolysis, damage to the tissue in the intestines. So it's going to cause the ulcers. The ulcers are going to be flask shaped. There will be flask shaped ulcers. The flask shaped ulcers are going to be seen here. Let me show you the image. They go here, guys. See here, there is an ulcer because of the entamoeba histolytica. They go how the ulcer is. The ulcer is like a flask. Okay, flask. So flask shaped ulcer is going to be seen. Now this is the organisms, entamoeba histolytica. Now they go inside the entamoeba histolytica. These are the RBCs. Okay, these are the RBCs. So this is something called as erythrophagocytosis. It will eat the RBCs. So there is erythrophagocytosis. Means erythro means RBCs are getting phagocytosed. Erythrophagocytosis is going to be seen. Okay, RBCs are seen inside this organism, sir. Okay, what else you should know is, sir, yes, of course, the cecum is going to be affected, intestines are going to be affected, malabsorption is going to be there, inflammatory changes are going to be seen, ulcers are seen. Okay, everything is good. So these organisms, entamoeba histolytica, okay, actually, let me tell you, it enters into the stomach. Okay, first via the fecal-oral route. Fecal-oral route. It enters into your body, means via contaminated food and contaminated water, it will start to enter into your body, sir. How? In the cyst form. The cysts of entamoeba histolytica will enter into your body. Where it will come? It will come into the stomach. In the stomach, what happens? Excistation happen. Okay, the cyst is going to open, sir. Excistation. The cyst will change. The cyst will change into the trophozoite in the stomach. The cysts are converted into trophozoite. The trophozoites are. the trophozoite, which is a feeding form. It's a feeding form. It's keep on eating the trophozoites. Now, this trophozoites, some trophozoites will come to the cecum. Okay, the good trophozoites, but some bad trophozoites, okay, they will go on a tour. They are going to for a honeymoon tour, sir. Where? To the liver. Okay, they will go to the liver and they will start to do the infection in the liver, sir. They will cause the liver abscess. Amoebic liver abscess. Amoeba is causing liver infection. Amoebic liver abscess. Okay, so whenever there is this amoebic liver abscess, sir, whenever you aspirate this liver abscess, okay, whenever you remove this fluid, abscess is there, right? So pus is going to be there. So this pus is going to look like amphobiasis appearance. So in the liver, it causes amoebic liver abscess. Amoebic liver abscess is going to show anchovy. Anchovy sauce. Pus. The pus is going to be like an anchovy sauce. Okay, the classical image, it's going to look like an anchovy sauce. Okay, anchovy sauce pus is going to be seen. Liver is going to be affected. The most common, like the site, the right, okay, the right superior quadrant is going to be most commonly affected. In the liver also. Okay, right lobe of the liver. That's what I mean by the right lobe of the liver. The right lobe of the liver is going to be most commonly affected. Okay, so these are some important points which I want you to know. The image-based questions: erythrophagocytosis can be seen, anchovy sauce pus. These are the microorganisms that are seen. And it's going to cause the ulcers. Ulcers are going to look like a flask shape. Okay, done. Now, next, this organism, sir, which I am showing you. This organism. So this organism is also going to infect your intestines and causes malabsorption. What is this organism? Can you guys tell me? Look at it and tell me what is this organism? This organism is looking like an angry man, angry old man. Okay, with this all broad eyes. Okay, the pear-shaped organism. So what is this organism and what is the disease it's going to cause? It's going to cause Giardiasis. Okay, Giardiasis. And what is the causative organism? The causative organism is going to be Giardia lamblia. Okay, Giardia lamblia. Now, some important points about the Giardia lamblia I want you to know, very important for your exam. Some important points from the microbiology also. There you go, guys. Sir, how you will get this Giardia lamblia in the cyst form? Okay, the infective form is going to be cyst form. You will get this in the cyst form, sir. Now, it causes what? It causes a diarrhea. Usually, this Giardia lamblia is going to cause a diarrhea in the immunodeficiency patients. Okay. Now, how you will get this? Via the fecal-oral route, contaminated water and food. Via the contaminated water and the food, you will get this. And what is the infective dose? This is important. So the infective dose is going to be very less, 10 to 25 cysts. So just 10 to 25 cysts are enough. Okay, very little number of organisms. The dose, the very little number of organisms is enough, sir. Okay, just if you get the 10 organisms into your body, it can start the Giardiasis. Okay, no need to have hundreds and hundreds of organisms. Just an infective dose of 10 to 25 cysts can cause the Giardiasis. Okay, what I want you to know is, if, for example, if I get one cyst, do you think it's going to cause a disease? No, that will be totally neutralized by my immune system. Okay, but a very low dose of 10 to 25 cysts are going to be enough for the development of Giardiasis. Okay, so this Giardia lamblia is going to have an adhesive disc or sucking disc. With the help of this sucking disc, okay, with the help of, I will show you, with the help of that sucking disc, is going to latch on to the intestines and it's going to cause a problem. Okay, so what is the test done? The test done is going to be intro test or string test. So the test done for this Giardia lamblia is the string test or intro test. MCQ. Okay, diagnostic test, string test or intro test. The shape of the trophozoite is very important, sir. If you look at this organism, it's going to be pear shaped. It's looking like a pear, sir. The pear fruit. Okay, pear shaped. And for someone it looks like a tennis racket. So they mentioned it as a tennis racket shape. For someone it looks like a spoon. So spoon shaped organism. From the sideways, okay, it looks like a sickle. Okay, sickle, sir. The one which is used to crop the, to chop the crop. Okay, so sickle shaped, right, sickle. Sickle is going to be looking like this, the sickle, sir. Okay, sickle shaped organism. So if you look at it, it's going to look like an angry man, angry looking old man. Okay, so angry man looking face. All these are for the Giardia lamblia. Okay, look here, this organism. So angry man looking face. Okay, angry man looking face, pear shaped. Okay, with the sucking disc. All these are the sucking discs. So pear shaped, tennis racket shaped, spoon shaped, sickle shaped, angry man looking face. All these are like important single in MCQs. Now the trophozoite form, the trophozoite form, sir, the feeding form. The trophozoite form is going to have the two nuclei. I will show you. And look here, this is a trophozoite. It's going to have the two nuclei, sir. Okay, so trophozoite is showing two nuclei. Okay, and how many flagella are there? One pair, second pair, okay, third pair and fourth pair. There are 4 pairs of flagella. Okay, there are totally 8 flagella are there. I should say 4 pairs of flagella. Okay, but if you look at the cyst form, how many nuclei are there? There are 4 nuclei, sir. Okay, there are 4 nuclei in the cyst, 4 nuclei in the infective form, that's the cyst, and there are 2 nuclei in the trophozoite form. Okay, so there are 4 pairs of flagella, that is 8 flagella. Cyst consists of 4 nuclei. Okay, there are 4 nuclei. Now MCQ, this is the MCQ which was asked many times in the FMGE exam. Motility. What is the motility? What kind of motility is shown by this Giardia lamblia? Giardia lamblia is going to show falling leaf-like motility. Okay, the motility is going to be falling leaf-like. Intro test. Okay, intro test or string test. The intro test and string test is also done for Vibrio cholera. That's a totally different string test. And this is totally different string test. So string test or intro test you will study in your microbiology. Just important points, right? Now let's see here. Giardia lamblia. It's also called as a grand old man of the intestines. Some important points, like let me write here. This is called as a grand old man of intestine. Okay, it was actually discovered by Leeuwenhoek. Okay, now it's the most common cause, Giardiasis. Okay, it's the most common cause of malabsorption. That's the important point which I want you to know. It's a grand old man of the intestine. I have shown you like what exactly it is doing. It's the most common cause of the malabsorption. Okay, most common cause of the malabsorption. It's going to see image based question also. See, it's looking like a sickle. Okay, it's looking like a sickle, sir, from the side view. It's looking like a sickle. So sickle shaped organism is going to infect your intestines. Okay, and going to cause the inflammation over there. Whenever there is inflammation, there will be flattening of the villi. Okay, there will be flattening of the villi. Usually it's not going to invade the mucosa. Mucosal invasion is not going to be seen. Okay, mucosal invasion is not going to be seen. It causes the inflammation. Yes, true. Leading to the malabsorption. Okay, done. Now the last disease which I want to discuss here is pseudomembranous colitis. Pseudomembranous colitis. So what exactly is the pseudomembranous colitis? Let me put it this way. Your intestines are having healthy bacteria. Healthy bacteria is there. Okay, intestines have healthy flora. Okay. Intestines have a healthy flora, sir. Good bacteria are there. But if you are for some reason, if you are taking too much amount of antibiotics, okay, if you are taking too much amount of antibiotics, too much use of, that is the inadvertent use of antibiotics. What happens? Like antibiotics, like this is also a question, like 3rd generation cephalosporins. The 3rd generation cephalosporins like ceftriaxone, okay, ceftriaxone, those kind of drugs, cephalosporins, or lincosamide group of drugs. Lincosamide. So using this drugs like 3rd generation cephalosporins and lincosamide, what they will do? They will kill the good bacteria. The good bacteria are going to be killed. Okay, good bacteria are going to be killed, sir. So these are actually good bacteria because they prevent the growth of bad bacteria. Good bacteria prevents the growth of bad bacteria. Because of some reason, if you are taking these antibiotics continuously, inadvertently, these antibiotics will also kill the good bacteria. Good bacteria is also going to be cleaned up. So what happens now? Bad bacteria will start to grow, and that bad bacteria, the causative agent. Okay, let me write here. The causative agent for the pseudomembranous colitis is causative agent is going to be Clostridium difficile. Okay, Clostridium difficile, sir. Clostridium difficile. Now this Clostridium difficile is a bad guy. He is going to start the inflammation. He is going to start attacking the the mucosa. He is going to start like the damaging the mucosa. So the causative agent is Clostridium difficile. It's a bad organism going to grow in the intestine and going to start the inflammation. Because of what? Because of the inadvertent use of the antibiotic like third generation cephalosporins and lincosamide. There is replacement of the good bacteria. There is replacement of the good bacteria with the bad bacteria, sir. Okay. Now, this Clostridium difficile, if you ask me, so this Clostridium difficile, it is going to release the toxins. It's going to release the toxins. Okay, it's going to release the toxin. Okay, that toxin is the one which is responsible for this, like pseudomembranes. You can clearly see here the glistening pseudomembrane, the glistening appearance is seen, right? Okay, with the pus. So the toxin which is produced from the Clostridium difficile is the one responsible for this production of this glistening pseudomembrane, a membranous kind of substance. Okay, that's the one. That's the important thing. Now, what else on biopsy? What you will see? Biopsy. So on biopsy, you can see this volcanic eruption-like appearance or the mushroom cloud-like appearance. Very famous question in your exams, both FMGE and NEET-PG exams. The patient is going to show volcanic eruption-like appearance. Okay, so the patient is going to have mushroom-like appearance or volcanic eruption. Okay, the presence of necrotic debris and the neutrophils. Okay, the presence of the necrotic debris and the neutrophils that are arising from the epithelium is going to look like a mushroom cloud. Okay, so biopsy is going to show what? Biopsy is going to show mushroom cloud. Okay, mushroom cloud or volcanic eruption. Okay, appearance like mushroom cloud or volcanic eruption, sir. So what is the treatment? Now, this is very important, especially from the pharma point of view. What is the treatment that is used for this pseudomembranous colitis? The treatment is going to be vancomycin. See, vancomycin, usually we use the vancomycin again in the parenteral routes. Okay, we'll never use the vancomycin in oral route. We'll never give the vancomycin in oral route. We'll use it in IV form. But the one condition, one place where the vancomycin is used orally. Okay, one place where vancomycin is used orally is this pseudomembranous colitis. Okay, that's the drug of choice. Vancomycin is the drug of choice. Oral vancomycin is used. But one important point for your exams, you need to know vancomycin. If you take vancomycin, it causes something called as red man syndrome. Vancomycin causes the red man syndrome. Vancomycin releases the histamine. Vancomycin releases the histamine, and the patient is going to have the red color flushing, red man syndrome, sir. Okay, red man syndrome. The treatment can be done with the vancomycin. Apart from vancomycin, you can also use the metronidazole. Metronidazole can be used. Fidaxomicin can be used. Okay, these are the other drugs which can be used in the treatment of pseudomembranous colitis. So pseudomembranous colitis because of the Clostridium difficile. Pseudomembranes are seen because of the toxin. On biopsy, you will see the mushroom cloud or the volcanic eruption kind of appearance because of the usage of the third generation, cephalosporins and lincosamides, broad spectrum antibiotics. Inadvertent use of broad spectrum antibiotics can kill the good bacteria. So in the place of the good bacteria, bad bacteria will grow and produces the toxin, cause the inflammation, leading to the malabsorption. Okay, and here Giardiasis, Giardia lamblia, grand old man of the intestines. Okay, pear shaped, sickle shell shaped, spoon shaped. Okay. The trophozoite is going to have the 2 nuclei, cyst is going to have the 4 nuclei, 4 pairs of flagella. Okay, falling leaf-like motility is going to be seen. Okay, these are some important points which I want you to know. A string test, intro test is going to be done for this organism, image-based question, sickle-shaped organisms. Okay, angry man looking face. Okay, the most common cause of the malabsorption. What is this? Flask-shaped ulcer because of the Entamoeba histolytica. Okay, Entamoeba histolytica causing amoebiasis. So this Entamoeba histolytica trophozoite form can also go and invade the liver, and in liver it can cause amoebic liver abscess. The patient is going to have the anchovy pus. Okay, anchovy sauce like pus that's going to be forming in the liver. When you aspirate, this kind of pus is going to be seen. Okay, so organism, if you look at this Entamoeba histolytica, this organism, so inside this organism what you will see, RBCs are going to be seen, sir. Okay, Entamoeba histolytica, histolysis, tissue destruction is going to be seen. So this organism is going to show the erythrophagocytosis, RBCs are going to be consumed, which is going to cause a bloody diarrhea, sir, bloody diarrhea. Okay, Entamoeba histolytica, bloody diarrhea, tissue damage can lead to the bleeding, so bloody diarrhea is going to be seen, sir. Okay, the most common site is going to be cecum. And what is this? Pos positive diastase resistant organism. Pos positive diastase resistant organism seen inside the macrophages. In the lamina propria, pos positive diastase resistant organism seen inside the macrophages. So this is Trophirima whippli. Okay, Trophirima whippli. So it's not only just the intestinal involvement, the CNS involvement, heart involvement, joint involvement, lymph node involvement can be seen with this Trophirima Whipple. And lastly, the tropical sprue which is seen in the tropical, like areas, tropical countries, because of this E. coli. There will be flattening of the villi going to be seen. So what we have seen in this class, we have seen about the infectious causes of malabsorption. Okay, pseudomembranous colitis completed, Giardiasis, Amoebiasis, Amoeba histolytica. We have seen Whipple's disease and tropical sprue. So all the infectious causes completed. Now in the tomorrow's class, okay, in the next class, we'll be discussing about the non-infectious causes. We'll be discussing about the celiac disease, inflammatory bowel disease, that's the Crohn's disease and ulcerative colitis. And also we'll discuss about the polyps in the colon, different types of polyps, okay, colon cancers, that will be discussed in the tomorrow's class, and all the miscellaneous topics, small miscellaneous topics, whatever are left over, that will be discussed in the tomorrow's class. So with the tomorrow's class, the gastrointestinal pathology will be completed. Okay guys, hope the class is helpful. See you tomorrow. Thank you.